Okay. So again, thank you for letting me talk with the group and help. Hopefully, we can collaborate on some more education issues. So AmSECT, the mission of AmSECT was to improve patient care and safety by providing continuing education to meet the professional needs of perfusionists. AmSECT's been around since 1964. AmSECT is not just me. We have a board of directors. Jim Rager is the president-elect. He'll be president next year. Our treasurer, Scott Snyder, and Theron Poor as secretary. And then we have zone directors that represent the different regions throughout the country. Here they are. We actually have two new zone directors, as Dan Gomez and Rob Longenecker have trialed off the board. And we have Greg Mork representing Zone 2 and Isaac Chinapan for Zone 3. So we welcome them. So what is AmSECT? It's the professional organization for perfusionists since 1964. We have a management group that helps organize us, the board, and organize our meetings and some of the education. We develop leadership education. And now I'm actually excited over this. Memberships, over 2,000 members worldwide. And that's a little over 40% of the perfusionists in the country. There are about 4,000 perfusionists. While that doesn't sound like a lot, if you think of AORN, there are 1 million nurses, operating room nurses, and 100,000, or only 10% of them are in their organization, AORN. But in that 100,000, that's a big number. So there's a lot of strength in that. And they were able to influence the OR dress attire, which is a big thing. Actually, we may be seeing some changes with that. And those kind of decisions are actually enforced by the Joint Commission and CMS when they come in for their reviews. We do provide education through our meetings and through AmSECT University. Good to hear that we're upgrading AmSECT University now. We have meetings. We're down to 1 to 2 meetings. We combine the adult and pediatric meeting now. We support perfusionists with other types of products such as Joint Commission kits, education on various technologies. There's a camaraderie, helps primarily at the meetings. It's interesting, the online meetings versus the in-person. A lot of people comment that a lot of what they learn is some of the post-meeting discussion. So that's interesting to see. We have many ways for members to become involved with AmSECT, all of our committees. Achievement recognition, the planning committee, some government relations. And that's an important committee right now, government relations, with some of the ECLS changes and CMS reimbursement. We had a group that was part of those discussions along with other ECLS members. We have the International Consortium of Evidence-Based Medicine, who help guide some of our publications. They also help develop the standards and guidelines that we are using now in both adult pediatrics and mechanical support. And here are some other committees. We have Leadership Symposium, develop leaders in perfusion to help make the groups even stronger. And then some of the other task force we have are with the blood banks, American Academy, Joint Commission, ELSO, et cetera. So this is what we're excited about right now. Membership, we got it back up to levels of almost close to 10 years ago. There had been a steady decline. Whether that has to do with newer perfusionists, there are trends in people being non-joiners. So we've gone outreach with groups, perfusion contract groups, and schools and programs, and we sometimes develop packages that make it a little more attractive for them. Here's a letter that I had recently written to membership, talking about the benefits of AmSECT, because I believe increased membership does help us in many ways gives us a stronger voice. It helps us enforce and model the standards and guidelines to improve practice. And these are important mechanisms that we're using to help improve the profession. So one of the newer pieces that we're putting out is the standards and guidelines. There have been questions about that. Who all had input? The board reviews this. The AmSECT board reviews the standards and guidelines. Then it's put out to membership for review and actually vote. So they were both approved. And most recently, the pediatric standards and guidelines were approved. We get questions about those regarding how pumps are set up, how teams are staffed, coverage response, education, and many pieces like that. So why would you want to join a professional organization? Primarily professionalism and collaboration. We are collaborating with the surgical organizations, the anesthesia groups like SCA and AORN to help develop some ideas in our standards and guidelines and help them to understand what we do. A lot of questions come in how ECMO systems are stored. It's common practice to have them stored for 30 days. And sometimes when an operating room nurse sees that, they are alarmed. But there's strong data to support that kind of storage. It also helps us to get out information to our membership and the profession. Many perfusionists specifically are very busy, and we can help them with new trends. We were talking about ECLS, remote kind of technology. Those kind of ideas can be discussed in our journals and at meetings. Legislation changes, we discussed that, and even support for licensure in various states. Why join? A shared common interest. Most professions have such a thing. It helps engage individuals both in the profession and to look after the public interest. Networking. Joining a profession association is a win-win situation for students because they go to meetings and network with professionals and possibly jobs. It's a nice way to learn about new techniques, speak with the speakers after talks, and get insightful reviews on that. Regulatory protection. In some states, licensure, either who does what in the profession, we can help protect that and actually not just protect it, but to provide the best care for the patients. And that's how it should be looked at. We work with the groups on education, standardizing education so that the professions and the perfusionists in the schools are all trained in a standardized way. And again, professional development. Why join? For credentialing, different credentials on ECLS, or VAD support, blood conservation. We have the IBBM. You get training in that as well. Professional recognition, just like physician colleagues, different designations for perfusionists on different skills they can learn and acquire. We also have professional recognition, the Gibbon Award. This is an award to honor a candidate making significant contributions in cardiopulmonary bypass, interrelating with the field of extracorporeal technology. It's one of our highest awards. The AmSECT Award of Excellence, another form of recognition presented annually to the perfusionist who demonstrates the work of excellence, exemplifying creativity and intellectual honesty. And the Perfusionist of the Year. So from the forms of education, we have our AmSECT University, and that's being updated now. We have the International Conference. There's training, pre-education going on at the conference, and then scientific abstracts that are presented representing some of the cutting-edge research by both students and professionals. We have a pediatric conference. We do combine at the international meeting. We have joint commission toolkits that we are putting together to help individuals when they do have a Joint Commission visit. And a lot of ECMO education or ECLS with some upcoming webinars. Safety education is one. We do a lot of safety polls on this. And these are some of the meetings that we have had: the Leadership Symposium, the Pediatric meeting, and then our bigger meeting is the AmSECT International. And this year was actually one of the largest meetings we had, with almost 700 delegates in attendance. So this was very good. It was in Nashville. So the cost to join AmSECT, it's not free, but it's $225 a year, 60 cents a day. You can't buy many things for 60 cents anymore. There are also group membership discounts, and they vary on the number of members that you can get to sign on. We encourage individuals that are members to recruit others. And again, this is important for the profession to help represent us. We do have a stronger voice in providing education, maintaining our standards and guidelines, or enforcing the standards and guidelines. So why join it? Again, in review, broadens your knowledge. I know Joe discusses some of the education he provides on MediWeb and PerfWeb, which are excellent sources as well. It can charge a career, either new groups that you may, a career change for a different hospital, for a career, or even just helping to make your career a little more complex by learning new techniques. Keeps you fresh, helps you build a better resume, enhances your network. And this is important for when you do have issues. Some people in smaller programs develop collaborative relationships with maybe larger programs, and help them when interesting cases or complex cases come to town, and they can learn or manage these patients well. Helps you become a better leader, organizational skills, become a mentor. In our leadership program, the participants in that actually become mentors for the year for perfusionists looking to take a leadership type track. Helps you make new friends, and again, strengthen numbers. It's also a way to give back to your profession, professionally, to participate in the organization, which is important, and to stay engaged and motivated. So my question, I continue to ask, how can AmSECT serve you better? We also actually have a survey with the American board, with the results should be coming out this fall. After all the research are completed, they're required to fill out a survey. And fortunately, the American board, we were able to participate with them for a survey for every perfusionist or every certified perfusionist in the country, which is around 4,000 people. And it has to do with education, some kind of staffing questions. And it will be the most comprehensive and largest survey ever performed for perfusion. So we're excited about those results. And that is the end of my talk. If there are any questions.
Yes, thank you, Bill. That was very, very good. And let me see, how can we get Bill back up? Oh, just stop sharing your screen. Yeah.
You're back on, right?
No, we need you. We need your camera. There you go. Yeah, hey, there you go. Apparently that's a Yankees jersey back there.
Yeah, Mickey Mantle.
Oh, really? Is it signed?
It is not. No, I have a picture of him signed, but no.
Very good. Very good. Excellent. Well, the only two perfusionists at the table are Mike and I. So I think that we may have some specific questions, but I feel like Dr. Samir, are you a member of your professional societies?
Absolutely.
Are
Yes,
you? You're a member of
absolutely.
STS? Are you a member of AmSECT?
Presently, no.
Presently, no. Do you have any professional societies you can be a member of?
Cell Society, Sales Associated Society, and the Medical Device.
But you are a member of those societies.
I am.
Okay, and are you a member of the STS? Okay, so why? I'm not a member of AmSECT, but I am a member of STS.
Well, first of all, I do have a baseball signed by Mickey Mantle. So this will let you, maybe we can get together and I'll show you my baseball and I can see that beautiful jersey, by the way, Bill. Anyway.
Would imagine maybe some Nolan Ryan memorabilia.
Maybe so. Maybe we can do that. I've been a member on and off through the years. Just recently, about 5 years ago when I joined a new company, Joe's company, at that point, I got out of it. I can't really give you a good reason why I did and why I have not gone back in. I think there are good things for it. I enjoy the CREF meeting every year, which I think is a great meeting. Been to the international conference many, many times too. Probably more than anything, I've got about 2 more years to really do this. And I figure at this point, it just is not, with only 2 years left to go, there's really not much more that I feel like it can offer me. Probably a very simplistic view, but that's kind of where I am.
Okay.
Well, Bill, I'm gonna take a big hand grenade, real big one, and I'm just gonna pull the pin and throw it towards you and say, here's the damn grenade. Do whatever you need with it. But I can tell you my story, and I think you're really doing a great job. Let me say first, of changing the paradigm of the society, the dynamic of it, the mission of it. I think you've done a fantastic job. However, I have over the past 13 years now, I am blocked, absolutely not allowed to advertise or to put on your event calendar my meeting that I was doing in New Orleans. It is not permitted. There was a time when, not you, but the organization under different leadership scheduled a meeting after I had scheduled my meeting in the same place, literally down the street from each other with only days of each other. And it created a lot of confusion. And we call that in the business of doing meetings predatory scheduling, and not really a cool thing to do. You guys had a recent, a few years ago now, but you recognized you called it the legends, but different people in perfusion that had been in perfusion for a very long period of time. It had to be, I think, a minimum of 30 years, and had also contributed in some way to our profession. And I think just sitting here at the table, Mike Brown, who's given any number of lectures and training with various different people at different hospitals, ECMO training of nurses at different hospitals around the Houston area, had been in the profession. He's been 37 years now. You're 37 years. I'm 40 years. It's hard for me to believe that you look that much younger than me, but yet you are still close to me in the number of years. And there was even Gary Cornelius from Houston Methodist, had been in the profession for 45 years. And somehow none of these people, including myself, made the cut. And then I recently got a call, it's probably been 6-8 months ago, I guess, from Brian Lick from president.American. And he actually called me on my telephone, and a very nice conversation, but he specifically asked me to stop advertising any of my educational programs on his event calendar, these are all ostensibly event calendars that are meant to disseminate information to the community at large. And one of your missions, and I think one of all of our missions, is to promote the advancement of our profession. So I guess I threw the bomb out there, and here it is. But if you want to know why I'm not a member of AmSECT, that's the reason.
Yeah. No, these are good questions, Joe. Critical questions. And some of the reason why I got involved with AmSECT. Some of the thoughts were maybe we weren't as inclusive, we were too inclusive or exclusive. sometimes when you mention where you were nominated for that I think it was the 50th anniversary probably meeting. Some of that comes from nominations from members. So sometimes people may get excluded if they are not members. I think AmSECT could probably do a better job looking out for that and sorting out people. I mean, Texas is, the home of open heart surgery, so there are a lot of legends out there.
The epicenter, certainly, yes.
I had an opportunity to go out there a year or so ago. It was an impressive visit. The advertising piece. I mean, I guess my vision for that is the way like STS does it. They kind of endorse a lot of other meetings. So if a region wants to have something, the STS gets their name on there. I don't know the intricacies of how they manage and set up the meetings, but they can get their name on there. They kind of endorse it. They may help organize it for content. And that's how I would like to see it. You can understand AmSECT needs to make some money to help with some of this education. I mean, I see the way you do it. It's got to be an expensive way, more so than my studio here. But I would see something like that AmSECT, if you're having a meeting, some way we can help endorse it, maybe help with speakers for you, and work with that. Maybe some kind of the sharing could be with membership. Part of the fee would be to sign up members. And I think that's a win-win for everybody like that. And that's something I'm trying to still push forward. I have another year to go on in this position.
Are you going to run for re-election?
Sorry?
Can you run for re-election?
I can actually, yeah.
Well, you know what? I'll join and vote. Okay, if you want to do that. So I think that at the end of the day, we have to just say what was, but what is and what will be. We have an opportunity here, an opportunity to work together. I think that, yes, I think that and I think that's why I love this panel so much, the diversification of it. I've got an anesthesiologist, a heart failure specialist. I've got a cardiac surgeon who's also a heart failure specialist. I've got a perfusionist, and I have an industry person. And, we've had so many different types of people up here that diversification, that inclusiveness really matters. And I think it would help with, you guys as well. And I feel like you guys, I don't want to make this a one-sided thing. I think that if we were to be able to come up with some type of program or plan where we were working together for a common goal, you would help me too. So this isn't a one-sided equation. I think that I would benefit greatly from a much better relationship with AmSECT than I currently have. So I'm extending my hand out to you, and hopefully we can continue these discussions and make that happen, because I do think the organization is important. I do think having a professional society is important. I do think having structure and guidelines and all the things that the STS provides for you and for the American Academy of Anesthesiology provides for you, or cardiac anesthesiology. I think these are all very important things. So that's my opinion.
And both you and Brian, you provide a great product for people, for perfusionists. So there's a reason why you're still doing this. And it's a reason that we learned from you as well. You're probably more nimble than we are. We have a board. When we want to do something, you have to get a big vote and such. And that can slow us down, but it makes it possibly a more thoughtful process. But no, I'm excited about this, getting to meet you, speaking with you prior to this meeting, and your nice public commitment to collaborate with us. That's great.
Well, thank you. So what do you think, Bill? What do you think about all of this discussion today about ECMO monitoring, doing it with telemedicine, perfusion telemonitoring of ECMO? I don't know if you listened to Dr. Samir's presentations and all the discussion. What's your thoughts on that?
Well, with the ECMO, I guess it varies in different states of who can actually run it. I like the idea of in maybe even smaller communities where you do have a telemedicine type setup that someone with a lot of experience can be reviewing it. You probably need a couple people on that in that center, like the call-in center or the monitoring center, to make it much more reliable. Because if someone was to get involved with something, maybe another hospital may be having an issue. And I think that could provide a great deal of quality and expertise to smaller programs that do it and make this technology more available. I guess in the scheme of things, when they say a perfusionist would be a lot of money, it's actually a small expense. But physically on a perfusionist to run these cases 24/7, because we have experience like that. Some centers we're involved with run 24/7, and others we do like a hybrid model where we train the nurses and in some respiratory therapists to run ECMO. In New York State, for example, they have to be licensed to be involved with it. So the unlicensed ECMO technician, I believe, couldn't occur in New York. But the training, getting more people involved, the systems have evolved tremendously from when I started doing an ECMO 30 years ago. They primarily bled to death, or the oxygenators would all leak within 6 hours or so. And the anticoagulation, physicians were able to develop models for anticoagulation that greatly improved or reduced bleeding, which made these a lot more successful now. We put people on that previously had the contraindications for ECMO, chemotherapy, or age, and now we're getting them off bypass. It's probably one of the biggest things in my career, ECMO, that we see 30-40% survival, and some categories even higher than that. But in general, it's someone that would have died after like a cardiac arrest, and now they're surviving. That's pretty amazing. Mm-hmm. And I think you need better training throughout the multidisciplinary team to be able to get those results. The physicians, nursing care for them, respiratory, and perfusion.
I agree with you.
So, yeah, the technology is a big bit, and I believe that's what's making a big difference. Some use the spectrum technology where they can see the monitoring, or EPIC, and to see the monitoring of the devices that the patients are on and the physiological monitoring, which is important that someone could be viewing it, an expert outside of the hospital, just for further support.
Mm-hmm. Well, I think that we basically are one epidemic. It's my favorite saying. We're one epidemic away from not being able to manage all of the potential ECMO patients that could come our way. And H1N1 stressed our system tremendously. And you still have patients that need to have heart surgery. So, yeah, and I think you said it, there's 4,300 plus or minus perfusionists in the entirety of North America, and you have 4 million nurses. And it essentially becomes a numbers game. And if one perfusionist can manage 4 or 6 nurses and ECMO patients remotely, then that's going to allow for more technology to be available to those people. That's what I think. Okay, I had a couple of questions, if I could. I want to plug, since you said, Dr. Samir, you mentioned Dr. Lumsden. Him and Steve Igo with his Pumps and Pipes meeting. That's a thinking outside of the box meeting.
Absolutely.
That they talk about, they bring in oil and gas.
NASA.
Medicine. And, have you been to the meeting?
Yes.
Have you talked there?
No.
No, he doesn't invite me to talk there either. But but I do recommend it. It's a great meeting, and that's another way to collaborate. I think is not only interdisciplinary within medicine, but collaborating with people outside of medicine. So Dr. Lumsden and Steve Igo, I think, deserve a plug for their meeting that they put together. Pumps and Pipes, one of the best meetings I've ever been to.
Yep.
Yeah.
And then how many times by you doing telemedicine have you actually kept, you talked about calling at the appropriate time, how many times have you kept a staff surgeon from having to get up out of their bed to go in to look at the patient to realize there's nothing that they need to do that day because they can't get all of the right information that they want on the telephone and they just go in because it's easier?
I tell you, I mean, I cannot even count. It's been numerous. Like, I cannot count. And sometimes I'll just tell them, I will call them before they come to the hospital. Well, I don't think you should come in because there's nothing you can do. We just have to do conservative right now. You just, in the morning, it will declare itself. You should do something or not. But, you have to give them the right information. It builds credibility with you, with the surgeons. Do you need them to come in right now? They can come in right now. If you don't need them to come in right now, then they don't need to come in.
Mm-hmm. What do you think?
It would certainly take, from my standpoint, some of the burden off of me having to wake up, become clear thinking, which, you're trained that way. But that's why I try to get as much information as possible as on my phone through Telegram to be able to make that decision. Mm-hmm. I guess I'm used to it. We do have in-house nurse practitioners now, but a lot of those are varying degrees of skill levels, and it takes time to gather confidence. And it's if it could be more standardized with that, if they're not going to provide an in-house pulmonary critical care physician or an experienced pulmonary critical care nurse practitioner PA, then that would definitely I would feel much more comfortable with, especially being an anesthesiologist and a pulmonary critical care CV anesthesiologist. I would have no trouble going back to sleep.
Exactly. Mike, what's your thoughts on all of this?
I look at it from the ECMO standpoint. I just see it as something that we're going to have to do because of the proliferation that we've seen in ECMO coverage. I mean, we go now with our small company in Houston, very seldom, less than 2 weeks in between our ECMO runs. And some of these ECMO runs are long, and they really hammer the staff. And trying to get someone to join your staff with already ECMO experience is rare these days. So when you add up all those little bullet points, it makes it very, very difficult to feel like you can continue the pace that we have been doing over the last couple of years. I'm sure most people in the country feel the same way. There's got to be another alternative, and I think this would be a great tool to allow us to accomplish that.
Yeah, it's almost got to be not even a seasonal thing for you guys.
No, it's not.
It's continuous.
It is continuous. Let me I have a follow-up question, if I may.
Sure.
You said you were about 2 years out.
About 2 years out.
Clamps,
That's true.
okay? For the last time, on the hook.
The golden tubing
The
clamp.
golden
Yes.
tubing clamps, exactly. But I'm going to get you a pair. But would this, if you had the ability to do what Dr. Samir is doing from your home office built with a telemonitoring platform, would this extend your career?
Yeah, it probably would. As everyone will probably feel, the hardest part about perfusion is being on call and getting woken up at 2 o'clock in the morning for another cath lab disaster. And it's like, oh, here we go again. I just did it Friday night, as a matter of fact. And, if you had a situation, as Dr. Samir is talking about, that you can stay at home, look what you need to do the same thing that you would do if you were on site. If you could do it off site, it certainly would extend people's careers.
Here's another question. Say this becomes, well, it's not the standard, but in order for it to become the standard, and for guys like you that want to retire but still do this, would that case count towards your pump cases?
I would almost pose that question to Bill. What would be your considerations on that, Bill?
That would be a new category,
Right, exactly.
and it's something that they need to look at. It's a pretty cool idea to have someone experienced.
I mean, I think that would be the benefit of it. You've got guys that are very experienced can do this stuff in their sleep.
Yeah.
And if they want to do it for another 5 or 10 years, it'd be a shame to put them out to pasture when they could
Still contribute.
get in there, get out of bed and sit in their underwear and, give advice,
Okay, as
long as-
long as we only have a one-way camera.
Well, you'd have to wear a T-shirt. But
Back to the question though. I've been calling you Bill. If it's William, my apologies. I
No,
don't know
Bill's
if
fine.
Bill's okay to. I'm with you. As they did, I believe I was one of the first people. One of my things that I really accomplished in perfusion is I wrote the American board, and I told them that you're going to have to allow for off-pump cases to be considered part of your 40 required cases a year. I think I was one of the very first perfusionists to contact them. So my first response back from them was, no, there's plenty of cases out there. And my response back to them was, well, one day it won't be.
Yeah.
And I think your comment about creating a new category is what we're going to have to do with these things as we see.
and maybe
that-
give those cases a half a credit or a quarter of a credit
right.
or something.
And that
I
has
don't know.
to be, I think so. And that has to be a collaboration because it's the board, the American board that dictates that. But again, a strong professional society with strong leadership is going to is going to represent their constituency, which is their members.
Right.
Or which are their members, as the case may be.
We have a simulation category, and if you've done simulation, it's a lot different than doing an actual case with the human being
Yes.
on the table. But they count those as cases as well.
But it has to be high def sim. It has to be an entire case. There's a lot of rules associated
Yeah.
with that. So it's not just as simple as a 15-minute simulation. It has to be a full, you go on bypass, clamp, pledge, the whole 9 yards. So it takes as long to do the simulation as it does an actual case for it to count.
All right.
Mike, any comments about all of this that we've talked about today, both representation and from a telemedicine perspective?
I'm a numbers guy, and from a numbers perspective, telemedicine works. We're seeing it. I mean, for example, early on in the program, I'd mentioned that the Cleveland Clinic posted some results of 60% less calls in the middle of the night, right? To where individuals don't have to get up. I think that's significant. It prevents burnout, and it fosters a better work environment. In addition to that, back to the numbers, it's in 2014, CMS came out and looked at how many telemedicine ICU hospitals were currently out there. And in 2002, there were 16, right? And now there's 213 by the end of 2010. So CMS is embracing it by looking at the facts, by looking at the numbers, and from a compensation standpoint, they're embracing it because didn't you mention that they're continuing to provide additional funds to?
Absolutely, because you're reducing like ventilation pneumonia, sepsis, DVTs, things like that. And you get reimbursed from CMS for not having these complications.
So there's definitely some parallels, and I think it needs to be looked at and considered for ECMO as well. So
Very good. I think that's very, very thoughtful. And you are a numbers guy, and we appreciate that about you. I'll tell you my first-hand experience with something that is somewhat similar to this. We were out together, and it was before we had started drinking, and you got called, which is rare, okay, for you, but we had gotten called to a hospital. One of your surgeons that you work with had some kind of endovascular procedure they were doing, and you needed to go assist with the, various different devices they needed to use. And you had questions about what to tell them, what would be the best option. And you had me hold my phone
true story,
up to the thing, FaceTiming to someone else while they were doing whatever they were doing to help give you some guys. This was somebody who was in a completely different state. And that's, I think, the beauty of telemedicine is you could be in a different country.
Actually, that's
It
what we're
doesn't
working on right now.
matter where you are.
And it had nothing to do with my product. It had everything to do with the patient. And we needed some coils. And there were a variety of coils on a cart. The physician needed them. I wasn't well versed in all of them, but I did know an individual that with Terumo that I trusted, and I called him and had Joe hold on to the phone. We FaceTime. We went over the various products that were available, and then while Joe was holding the phone, I'm pulling products, opening the coils up, and we're collaborating, the physician, myself, Joe, as well as the sales associate on the other end.
Well, my job was to be the robot holding
Yeah.
the camera. That's all they trusted me for in this case.
But the outcomes were
you're
successful.
Yeah.
And we couldn't do what my products were intended for unless we resolved the issue with the coils to prevent bleeding.
Mm-hmm. So I thought that was I had that firsthand experience. I mean, this is tech. We have not yet caught up to technology, basically is what it comes down to.
Right.
You know, what we feel comfortable with as human beings is just so down here when technology is already way up there. And Bill, any final thoughts on all of this?
Well, I guess we're a little slower because of the product we work with, the human beings. No, but it's fascinating what we can do with technology. I think we're on the way with that different type of monitoring that you spoke about. I guess the big thing with things like ECMO and all is getting the people who cannulate. That's the question I always had. People talk about having less trained or even non-surgeons trying to cannulate. I had done a talk on cannulation, and when you actually see the differences in anatomy and everything that can go wrong, it's hard to believe anyone else but a cardiovascular surgeon should be cannulating a patient for, especially an ECMO, when they may be pulseless. So under the worst conditions, you probably want to have the best qualified person now. I don't know if you have any thoughts on that, how to improve the access.
No, I do. I mean, so let's just hypothetically say you have patient X, and patient X is dying, and without ECLS, patient X will definitely die, and you attempt to put the cannulas in, and they go retroperitoneal, and it doesn't work out, and patient X dies. Well, they had at least a chance because the cannulas might actually go in the right place, and patient X actually lives. So you have a known outcome, which is death, and then you have somebody putting cannulas in. I think they should be trained. I think
I've seen heart surgeons do it too.
Yeah, even heart surgeons
But I agree.
can go
Your
retroperitoneal.
point is correct. If I have my choices, I would rather be the ones putting it in, especially I'm going to be part of managing it, because there's just that feel. However, back to what we talked about earlier when we had our piloted ED ECMO institution program at a Northwest hospital we worked at, that Joe basically did all the education for, sent all the emergency room physicians that were either interested or coerced, because we definitely needed a number of individuals trained, and also pulmonary critical care, whether they wanted to be trained or not. Joe was institutional in getting that started, and how many times do we see him cannulate the wrong artery? It was
Never.
I don't think it ever happened,
Never.
even with somebody who was pulseless. So, that is a question and a problem you foresee. But Joe's point, as far as when you're dead, you're dead.
Okay.
What choice do you have?
Okay, look, I've got a little
Other
bit of
than
life.
not doing it.
I've got a little bit of life left in me. All right,
Yeah.
It ain't much, but I got some. Okay,
Right.
If I end up going down on this floor right now, and you come over there to help me, and you trip and fall, and you break your leg and can't get up, and you do the same thing, and I'm left with those two to stick the tubes in, you know what? He can FaceTime, and he can put them in, because he's probably seen it enough times to do it.
He's seen it more than I have.
If I die anyway, at least he gave me a fighting chance.
I agree.
Try. The outcome is known. It's bad. So I'd rather you at least gave it a shot. Give me a shot.
I like the argument. I've heard some groups putting in smaller cannula to
Correct.
make it safer.
That
Like
was
15 French.
absolutely. That was the other point I was going to make. Just get some partial support till
Yeah.
you can, and that was
Yeah.
part of our program as
Something.
well, because it's easier
Okay.
to put the smaller ones in, and then by then, depending on if it happens at 5 o'clock on a Friday in Houston, it is an hour and a half for me to get from one hospital to the other.
Yes.
And
Sure.
we maybe only be 20 miles apart.
And you can see the two of them together. Yeah.
Right. Exactly. And so yeah, partial support is better than no support. And those are, and that introduces a level of comfort for those physicians that aren't very, don't put cannulas in every day. I mean, but that I would say that we never had one out of how many did they do? 40,
Yeah,
50?
at least.
Put it in the wrong place. We had about a 50-60% VV survival. But our VAs for arrest, we actually had two walkout,
Two major saves.
but we had 4 or 5 that became organ donors for whatever that's worth. But I mean, it helped somebody. I mean, they were brain dead, but everything else was alive. I mean, it was amazing. You'd see some of these hearts, stone heart on echo, and then a day later they're working. So
Yeah, no, it's an interesting argument because you see some surgeons who want to get involved with it, and they start, and then they just get burnt out trying to manage like an ECMO program by themselves, coming in all hours of the night, cannulating.
No.
I turned it over to this guy.
It takes
Literally, I turned over to him and the pulmonary critical care guys because the cardiologist didn't want to have anything to do with it.
and I don't do anything with it. I turned it over to that guy because they don't let me go in there very often. Listen, when they call me and
You
say,
can
"Hey,
tell now."
can you watch an ECMO?" I'll do it, but they're more scared than I am. I'm almost too. I think I have a little bit of early dementia. But listen, we're going to. I think we're going to call it a day. It has been truly a true privilege to meet you. It has been a true honor and privilege to have you here in our studio. Dr. Matoyer, the same. Mike Brown, and Mike Brodowski, thank you both so much for taking the time out of your Sunday to be here to do this. I think it brings a lot of value, and you all being here brings the most value of all. Thank you.
Thank you.
Okay, great program. Thank you very much.
Thanks.
Thanks.
Let's
Thanks,
not
Liam.
be strangers.
Yes,
Okay, be safe.
continue it. Thank you.
And everyone else on Web World, please take a look at our website in the next few days. I'll be putting the second half of 2019 schedule up. The evaluations will be up. You'll be able to fill those out. Please let me know what topics you would like to hear about, experts you would like to hear from. Get involved with us as well. Bill, please have your members call if they'd like to be a part of PerfWeb. They could do it just like you did it from the comfort of their office or their home office with baseball pictures behind them. It's great. But that's what makes this such a fun program, is that it is interactive. Everybody has discussions, and you can be part of this also, and part of essentially what I call the revolution in continuing medical education, with decreasing reimbursements, no CEU budgets, staffing issues, not being able to get away. And you want to watch a program that is not only required, but that is interactive, enjoyable, informative, educational, brings value to your practices. That's the goal. So thank you all. We'll see you next program.